Hi, this is Brian Kim. I'm going to share with you case number 269 in the Best Way to Do Cataract Surgery series. And the title of this series is not to suggest this is the best way or the only way, but to get you to think critically of your technique so that you can provide the very best for your patient. And so this is a somewhat of a dense cataract, but the nature of this cataract is that it's rather sticky. So the epinucleus and the endonucleus is rather sticky, and it's really difficult to crack in some of these lenses. So you're going to see me perform terminal chop, cross chop, and then techniques in using the chopper to pull pieces into the center and not using vacuum to going after pieces in the periphery. Using the cotton tip to steady the eye, and then using a corneal marker to help me center and size the rhexis. And I really use that cotton tip a lot in the beginning of the case for my early parts of the procedure. This is my 1mm paracentesis incision, first on the right side and then the left side, making sure I'm flat to iris plane to get a nice shelf, which will allow me to achieve a self-sealing incision. Again, using that cotton tip to control the eye. This is intracameral epinephrine, and then dispersive viscoelastic to fill the anterior chamber. And I use that viscoelastic cannula to control the eye for my triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel, and then when I'm ready, I enter. So using that cannula and always using a second instrument to help aid my technique, whatever it may be, using a cotton tip to control the eye, using this cannula to control the eye. So again, using this same cannula to control the eye so I can do my rhexis. This is the Morio microrhexis forceps. I puncture the center, pull down towards me, grabbing the right side of the tear, going around circumferentially. You can see it's a rather dense lens, trying to remember where my corneal mark was and trying to follow that mark as I continue the rhexis. But you can see I have great control. The low profile of this forceps really helpful. Very little OVD egress as I do the rhexis. You can see the action of the tip is nice and wide. I'm able to grab rather easily. And the tip is sharp, so I'm able to puncture the capsule easily as well. Finishing off the rhexis, burp some viscoelastic out, coating the corneal surface with the viscoelastic. You want to wet it first before you put that viscoelastic. It creates a more smooth surface. This is the capsule fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, do a little bit of a wiggle to make sure I'm not against the posterior capsule. As I push BSS and get the wave, I lift the lens up, which allows me to decompress the lens. And you can see that loosens up the lens and the lens begins to spin. Lifting the incision with the chopper. This is a kin chopper. It's a right angle chopper. This is a chopper I use for all my cases. It's a little bit longer, which increases the efficiency for the double chop, cross chop, vertical chop, double chop, all the techniques that I employ. So you can see it's a rather sticky lens. I try to remove the surface epinuclear material. Nothing really came out. So I switched to sculpt. We're going to create a trough. Again, somewhat dense, not terribly dense, but again, with this sticky type of lens, I'm just trying to create a little bit of space. And again, the sticky lenses to me are the most annoying type. So just create a little bit of a trough, go back, bevel down, place a chopper under the lens contra-incisionally under the capsule, performing a terminal chop, crushing the lens against the phaco-tip, performing a cross-chop maneuver, placing the chopper under the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco-tip, and fracturing it against the phaco-tip, crushing the right heminucleus in half. Again, placing the chopper under that first quadrant, bringing it towards the phaco-tip, crushing it against the phaco-tip, grabbing that first piece up with some vacuum, and then again crushing it using mechanical forces, and then emulsifying the piece. Turning the second quadrant towards me, cracking the second quadrant away from the rest of the lens, performing another chop maneuver, placing the chopper around the lens equator every time, By hooking the lens equator every time with the chopper, I'm able to pull it centrally, crushing it against the phaco tip, and performing very effective and consistent chops without having to rely on vacuum or ultrasonic energy. So as you can tell, every time I fracture the lens, I'm not using any ultrasonic energy or vacuum. I'm using pure mechanical forces. So I turn that second heminucleus in front of me, placing chopper around the lens, using a little vacuum to lift the lens up with the phaco tip, getting around it, flanking the lens with the chopper and the phaco tip, cracking it in half. Sliding the chopper under the third quadrant now, hooking the peripheral lens, and then pulling it centrally toward the phaco tip and crushing the lens against the phaco tip. Using some vacuum to grab that fragment up. It doesn't want to come, so I hook the peripheral lens up, lifting it out of the bag, crushing it between the instruments, and then emulsifying the lens piece. So anytime you have stubborn pieces, don't go after it with vacuum because you don't really have to. The better habit is really to hook the peripheral lens and get the lens piece up. Again, you can get away with using vacuum, but in situations where you're in trouble, let's say you have an anterior capsule tear, posterior capsule tear, or zonular disease, much better to rely on your instruments and mechanical forces rather than the fluid, because the fluid is really moving at a high velocity. So you might be grabbing things that you really don't want to. And so in situations that are less controlled, using mechanical forces is really to your advantage and really will keep you out of trouble. So the rest of this is just using mechanical forces, grabbing the lens pieces up with a little bit of vacuum to get it on the tip, and then crushing it with the chopper, and then emulsifying the lens pieces. So you can see the CDE is 9.77. Most of that was from the sculpting early on in the case, so there should be good corneal protection from the viscoelastic. So little endothelial trauma with this technique. Now I'm removing the epinucleus, which you could tell is rather stiff. This is that type of dense lens. When it's sticky, that's kind of the precursor to the hypermature cataract, in my opinion. So we got all the epinucleus out now. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. Start subincisionally, trying to peel from anterior to posterior, sweeping side to side, trying to grab large sheets of the cortex so it comes out cleanly. Staying subincisional, going around circumferentially. The polymer tip is excellent tip. It really helps reduce the risk for damaging the capsule during this step. Switching to polish mode, polishing the posterior capsule. You can see there's some fine cortical material that's adherent to the posterior capsule. I'm able to peel it off rather easily. And then sweeping and polishing under the rexus edge as well, and grabbing some of this hidden cortical material. Again, polish mode is just very safe, and it allows you to be able to blindly perform vacuum with the INA handpiece. Once it's clean, I'm going to pulse BSS into the subincisional capsule fornix, and sometimes there's some fine lens material that's still trapped there. Turn off irrigation, and then push cohesive viscoelastic to fill the bag, taking care not to allow the iris to come out. So you want to be mindful not to push too much, just enough to blow up the capsular bag, not to increase intracameral pressure. Using the sweeper to sweep on the left side and right side underneath the rexus edge, And then this is a single piece acrylic lens going through the main incision. And now what I like to do, because I've had a few cases where when the bag is not fully inflated that it led to a posterior capsule tear, I always refill with viscoelastic. And this is the AR40 lens. It's going into the capsular bag. And I really like this lens. You know, if the bag dislocates down the road, you can use the AR40 lens to perform scleral fixation with the Yamane technique. So gently positioning the optic in, pushing some more cohesive viscoelastic to fill the bag, and then dialing the trailing haptic into the bag with the Maltzman. Go in with irrigation off, activate irrigation, getting the INA handpiece underneath the lens, tilting it and removing all the viscoelastic from within the bag, tucking the optic back into the bag, polishing under the rhexis edge, and then removing the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is, standard technique of a dense lens with a sticky material, a lens material. The sticky ones are tough because when you try to crack it, they just don't tend to separate well. They tend to like try to hold each other. And so you saw I perform terminal chop, which is essentially creating a central groove and then performing terminal chop, placing the chopper under the rhexis edge contra-incisionally, placing the phaco tip deep in the trough, and then crushing it from the terminal side, which very easily and consistently propagates a separation in the lens into two pieces, and then performing the cross-chop maneuver, placing the chopper around the right heminucleus, pulling it centrally toward the phaco tip and fracturing the lens against the phaco tip, and then utilizing a lot of maneuvers, just crushing the lens using the two instruments with mechanical fracturing techniques. And then once the pieces are small, you can just emulsify the pieces. It really reduces your CDE, reduces your endothelial trauma. You tend to have clearer corneas with this technique. In my experience, using terminal chop and then the cross chop and then maximizing mechanical fracturing forces is really advantageous with these dense lenses. And anytime you're worried about zonular disease, in my opinion, it makes more sense to use a three-piece lens, because if the lens or the bag dislocates down the road, you can use this AR40 lens for the Yamane technique. So I hope this was helpful to you, and I thank you for your attention.